All right.
All right. Thank you.
This is Committee Member Anderson, and welcome back, everybody. According to our agenda, the next item to discuss was the vaccine protocol format discussion, but we will not be discussing that today. And instead, we're going to move on to begin with the election of a committee chairperson, which is a 2-year term. So traditionally, the committee chair serves for a 2-year term and expires during their tenure, or members with terms that expire during their tenure as chairperson would need to be replaced at their final meeting, which I believe I'm currently the chair, and this is the end meeting of the year for my second year. So if the committee chair is unable to attend a meeting, agency staff will make arrangements with another committee member to moderate meetings, and committee members will nominate a new chairperson and then vote. So do I have any nominations that anybody would like to throw out as the new chairperson for the Public Health and Pharmacy Formulary Advisory Committee? These self-nominations as well, if others would like to. Bless you, Rosa.
Can we nominate people that aren't here? I'm just kidding. Sorry. What about Dr. Myers? Okay.
Sorry, my plate is very full.
Dr. Virgin?
My plate is also very full.
Andrew?
What is, yeah, we're all going to say that, but what is the time commitment of being chair?
It's not a lot, to be honest. So Rachel will send out essentially a script, which is what I read from every time. If you guys, because I do not know all of those ORS numbers, for instance. So I just read them from a little script that Rachel sends out. And then I help to, I guess, like moderate discussions like you guys saw. There's not a lot beyond that. It's just showing up to meetings and helping moderate the meetings.
How long are our terms? Are they 2 years?
I think so, yes.
Mine's almost done anyway, I think.
So I think what, like when you're first put on the committee, it's a 2-year term, but then you are allowed to reapply for another second 2-year term. And so if you would like to reapply and be the chair now, you would be able to be eligible for another 2-year term. I'm already into my second 2-year term.
Yes, this is Staff Member Melvin. Committee Member Gibler, your term goes through the end of April 2025, but we were going to ask if you are interested in being reappointed. And then Catherine Hammond's term also expires at the same time. And Dr. Myers are all May of 2025. Sorry, April of 2025.
Okay. I've chaired so many committees. This is not something I want to do, but this is a lot more of us. I can do it, but it's unless Courtney, you want the great experience.
Courtney, would you like to do
it?
Welcome to the committee. Would you like to chair it?
Yeah, that's the only thing. I mean, this is really my first real full meeting, so I don't know that it would be the best fit just yet, but if absolutely nobody else wants to, I could do it.
I will say that that's when I took on being chair as well. I think was in my first meeting, if it makes you feel any better.
Okay, so do we have a nomination or do we have two? No?
I can't decide. It sounds like Andrew is willing to take it begrudgingly. Courtney
Well,
is.
no, it's not begrudgingly. I'll do it. But I
I'm
just, if
sorry if
there's
that was a
anyone
bad
that,
term.
if Courtney wants I don't know your experience, Courtney. If you'd like to take it on, please do so. Otherwise, I'll do it. It is good experience, but I don't know your experience level. Maybe.
Well, I work in, I'm a pharmacy manager at a local hospital, so I feel like I do a lot of committee
chair a lot
chairing and
too.
project work. So I have
Right.
a decent amount of experience with that. I just don't have any experience in the government realm. So
There's a
I
lot
would
of
be, I
ORS numbers.
love the ORS numbers.
You
To look
you
them up
have to
every
memorize
day.
all of them.
I would be happy to, but I don't know. I mean, if people aren't comfortable with me and I'm fine with that too. So I think we should duke it out, Andrew. I'm just kidding.
Oh, I'm gonna, since you said you'd love to do it, I'm gonna nominate Courtney Sellers.
Okay.
Committee member Myers, I'll second.
Awesome. All right, so it looks like we have a motion to elect committee member Sellers as the chairperson for a 2-year term effective on January of 2025. And we've had a second by Dr. Myers. So I approve committee member Anderson and then committee member Gibler,
I
committee member Myers,
Aye.
committee member Sellers,
I
and committee member Virgin.
Aye.
Great. Thank you, everybody. This motion passes. Courtney, you are chair starting in January. So committee member, oh, looks like I have a little script too. So committee member Sellers has been elected to the chairperson of the Public Health and Pharmacy Formulary Advisor Committee for the next 2 years. And we will move on to our next agenda item. So now we're going to discuss future formulary committee meetings that are scheduled to be held in 2025. We have a couple of proposed dates for the virtual meetings. Traditionally, we've met on Wednesdays. And so for planning purposes, the following dates have been identified. The first one is 4/23 of 2025. So April 23rd. Does that date seem to work for other people, at least so far? I know that's what, 5 months in advance. Nobody's planning on being out of the country. Big long trips, anything like that.
No, it's right during the school year, so I'll be home.
Yeah, I know what you mean. All right. The other date that is being proposed is October 22nd of 2025, also during the school year, Andrew. Any concerns with that date? All right.
Are we not, that's just 2 dates. So, with the vaccine protocols, I was
I
thinking we
know.
need to meet often. But
I feel like those ones, whenever ACIP meets, we end up getting an email that asks if we can. Yeah, I see Brianna nodding her head in the background there. Does that sound about right? We tend to meet more frequently, you're right? But I think that we get asked about that whenever ACIP meets. And do we know when ACIP meets out of curiosity? Is there like a
So it
schedule
seems
that
to
they have?
it seems to be between July and August. It's not the same time every year. And yes, you're correct. Unfortunately, we have to sometimes call a special PFAC meeting, depending on how it lines up with the board meeting for them to adopt the protocols.
And those would just, Oh, go
Oh,
ahead.
sorry. I just wanted to share, I think we went back and forth on this and putting another meeting on the agenda, and it just seemed like if we set something, it might need to change, and that it might be easiest just to kind of have that understanding, especially in the fall. We know there's some recommendations for late summer that are going to come out, that we would just be prepared to give us as much advance notice as we could to have a meeting instead of putting something on the books and then having to change it multiple times. But we're open to suggestions on what would be best for the committee.
Does the committee feel strongly about trying to get some dates planned in advance versus requests to meet as they come up? Yeah, Dr. Virgin.
Committee member version. I'm fine with us having those placeholders and then looking for a date that might work should something come up, and having an ad hoc meeting based on need and ASIP recommendations.
Great. That does look like it's a bit of a consensus. I'm getting some thumbs up and nods from other people. Perfect. All right, let's leave it that way then. It doesn't look like this needs a vote. So we're going to move on to the formulary and protocol review for the VVC, vulvovaginal candidiasis, first. So I believe that was sent out to you. Are there any, that was something that I believe we would need a motion to I'm trying to remember what the verbiage is that we had during the executive session.
It'd be a motion to repeal the
Um,
BBC statewide.
Which you have, but I think the committee probably needs to discuss it.
Yeah, they
for
can-
the public's sake.
Okay,
'Cause they're,
yeah,
so
we are in the public set part now. Yeah, so is
so
there,
this was mailing A, by the way, what we noticed to the public.
okay. So any discussion about this? This was something discussed in executive session that we had proposed that we would be going ahead and repealing this particular protocol. Is there any public discussion that the committee members would like to bring up, discuss at this point?
For the public, it sounds like the Board of Pharmacy had concerns about pharmacists using this protocol and diagnosing, which is outside of their scope and without statutory authority to diagnose based off of symptoms. The PFAC had discussion in executive sessions about some of the concerns that, yes, indeed, this may be diagnosing, and repealing it for now and going back and maybe having a subject matter expert look at it to see if there's ways to modify it so pharmacists aren't diagnosing might be an approach. But for now, to repeal it because it may be against statutory authority as it stands now. This is what I understood. So I just want to make that public.
This committee member Anderson, thanks, Andrew. I think I very briefly saw Dr. Meyer's hand up, or was that an accident?
No, Committee Member Myers, I was going to chime in, but Committee Member Gibbler did a nice job of summarizing, so no further things to add.
All right. Can I get a motion to move to repeal the vulvovaginal candidiasis? I might have, did you send me a new email? Because the one from this morning doesn't have it.
Yeah, so right under the letter A for the mailing, if you just look right below that,
It says, is there a motion
to move to recommend the repeal? Might have scrolled maybe too far.
Lorinda, I can just read it if you want me to. That's helpful.
Sure.
Okay, so is there a motion to move to recommend the repeal of the VVC statewide drug therapy management protocol version 06 dash 2021 to the Oregon Board of Pharmacy for review?
Committee Member Myers, so moved.
You have a second?
Committee Member Virgin seconds.
Thank you. And I am actually back in the right place now. Thank you, everybody. Sorry about that. So Committee Member Anderson approves Committee Member Gibbler,
Aye.
Committee Member Myers,
Aye.
Committee Member Sellers,
Aye.
and Committee Member Virgin.
Aye.
All right, this motion passes. All right, we are now moving on
Just
to,
quickly,
Yeah.
did you want to recommend that the board consider putting together a different version of a protocol on this topic?
oh, that's a good question. How did that'll be a bit of a discussion.
No, I'm sorry, that Gary, sorry, not the board, that Gary put together a different version of the protocol to bring back to you. Sorry, not the board.
Does this
Or do you want to just
committee-
let it be?
This is Committee Member Anderson. I guess I'm kind of curious, like if this committee even thinks that there's a version that would be acceptable. Like, do we think there had been some discussion about like, if there were a test maybe that could give you some objective data to go off of, like, do we think that kind of stuff exists out there? That could help with adjusting this protocol? For instance, that's just an example that I'm thinking of. I'm trying to imagine a world where this protocol would work for pharmacists. Dr. Myers? Sorry, Virgin.
Yes, Committee Member Virgin. I do think that it would be worthwhile to send this back to our subject matter experts to see if they could retool it in a way that would allow symptom-directed treatment without diagnosis to meet the overarching goal of this protocol in keeping with ORS guidelines.
Okay. Any other committee members' thoughts?
Well, I think also if we have to do some acrobatics to make it work, I think maybe Gary can just, is there a way to let us know without actually introducing it and reviewing the protocol and putting the work into the protocol if Gary or the SMEs look at it and there's just no way they can tackle it? And do they have to, at least with this motion, actually put together something that we will again reject?
So I think what you could do is you can provide the direction, and then if they get into it, right, he could always bring it back and be like, we don't see any path forward.
Yeah, okay. Perfect. I just don't want too much work being done if it's a stretch.
This is Committee Member Anderson. Yeah, I agree. I maybe put a little bit of time into it, but if you are starting to see that it may not be something doable per statutory authority, that you let us know. That sound good? That I'm getting some nods. Okay.
Does anybody disagree with that plan?
No, it looks like that's a good plan. Is that something we have to vote on?
I mean, it's just recommendations. You don't, unless anybody, that's why I was like, does anybody disagree? Because if they did, then maybe we should have a vote to figure out whether or not. But if everybody's generally okay with it, then I think it's recommendation to be, provided to the staff to work on and bring back.
Okay. Thank you, staff.
Reasonable.
And SMEs. All right, any other discussion on BBC? Before we move on to next agenda item? All right, next agenda item is to look at the contraception statewide drug therapy management protocol, version 11 of 2024. So I think I'm going to turn the time over to Gary. Are you taking this on?
Staff member Onion Nest, that would be correct, though hopefully with your help.
Yeah, so
I think this
for
is
those,
a
yeah,
baby of yours. I believe
this
I've
was
been
my
told.
doing. Yeah, this is committee member Anderson. For those who aren't familiar with me, I kind of got into, applying for this committee and things like that because I helped years and years ago with the original contraception protocol. Back in 2015 is when that one, before the PFAC committee was even developed and put forward. So it was kind of our very first statewide protocol. Unless you consider, OHA's immunization protocols from back when. So this protocol, it did get brought under the PFAC a little while ago. But the reason, and I put in to ask to have this particular protocol updated because the guidelines updated for those that aren't familiar with what the guidelines are for contraception. It comes from the Centers for Disease Control and Prevention. They put out something called the U.S. Medical Eligibility Criteria and an accompanying guideline called the SPR, or the Standard Practice Recommendations for Prescribing of Contraception. And they go through every single type of contraception. The type that pharmacists are allowed to prescribe for are more self-administered types, which include your oral, transdermal patch, vaginal ring, and injection. And so that's what I focused on. The documents that Gary Runyon sent you in the email, or actually, I guess Rachel sent the big email. Sorry about that. There is a document in there that I created. So if you were kind of curious what that is, the CDC puts out a really cool summary table of their recommendations for prescribing, which are broken down into 4 categories. A lot of this may be so old news. So let me know if you need more guidance on this, but pharmacists are able to prescribe for categories 1 and 2 and are not allowed to prescribe for 3 and 4. Yes, Andrew.
Committee member Gibbler, and I didn't mean to interrupt you, but just on a broad level, this protocol includes all legend and OTC oral contraceptives as well as the transdermal and injectable.
Yeah, thanks for that. So it does include, especially because there has been a new product put out that was just approved by the FDA for over-the-counter hormonal contraception. It's a progestin-only pill. Brand name is O-Pill. The generic name is Norgestrel. And so pharmacists could definitely prescribe for that. This particular one does not include emergency contraception. There is actually a separate preventive care protocol that is specific to emergency contraception. So this one does not include that. Those are over the counter as well. Well, actually, I'm sorry, just the levonorgestrel type is over the counter, but the other protocol includes ulipristal acetate, which is another available but prescribed EC that pharmacists could prescribe for. So back to the updates that were made for the in the guidelines from the CDC a few months ago. When I looked at the updates, I felt that it was easiest to kind of take their table that is a synopsis table and go through that. And I went and made little annotations throughout it as to when the category numbers changed, or if there was even a brand new category added to it. So that was the other document that you saw. That's not intended to be included in this protocol, but it was more of like my trying to show where things changed so that when we update our table in this protocol, you'll sort of see where things changed. So this, I don't think there were a ton of changes in this. Is that correct? I think this was just the front page that had, so we'll need to change some links on this first page for where to go for the correct up-to-date guidelines. So I think that's really the only big changes.
Correct. That's Staff Member Runyon. This is mailing A1 and A1A, just for the record. And then, unless otherwise noted, these will be the versions that were sent out to all of you. And there are a few instances, Lorinda, as you know, where Jen has provided some additional feedback after these were mailed. So I'll be sure and indicate what documents those are, and then they're all listed via the notes, so it'll be evident what feedback she's provided that you may not have initially seen as well. And then going down through the list, you're correct. This one is just related to the link there, so we can update those without any problem. And then the last thing on this document, the lower right-hand corner, is your comment about self-administration, I believe in. There is a comment in the next document, number 2, where that's addressed.
Yeah.
I think that does it for this page, unless anyone has any additional comments or questions, concerns.
Yeah, that's a good point. I do want to clarify that comment that I made. This was something that under the rules and contraception, but then when we brought them into the PFAC committee, this committee felt like it would be appropriate and could be something that pharmacists could prescribe and dispense the sub-Q formulation of depot-medroxyprogesterone. So this was an update that was already made under this committee. And so that's why that resource is there. And I think I was just clarifying that that was the case, because I did make a few adjustments later on to sort of reflect that adjustment, that pharmacists could do that. And as just an FYI, I mentioned the SPR. That is a recommendation in the SPR that patients could and are able to self-administer as sub-Q injections. Are there any questions about these before we dive into the next documents?
At the committee member Gibler at the bottom, what does APP mean? The
ATT.
first bullet point. GDC, US, MEC, and US. There's a lot of abbreviations there.
Oh, it's an app. It's literally a downloadable. It's an awesome app, by the way. I actually teach my students to use that app. It's whenever I teach this, it's a really cool resource. Yeah, it goes through both the US MEC and the SPR, and it has it broken down by either. You can choose to search it with the contraceptive method or via the condition. And so if you go into like condition, it'll tell you what all the categories are for each of them. And then it will give you even like more clarification if you click into things further. So like one of the things I'll do with my students is I'll have them, you know, like look at different conditions based on how a patient might answer, you know, or self-identify different conditions, and then say, what would that, you know, category give them per the MEC. So it's a really, really nice app.
Thank you. As for clarification, should we provide just the links for downloading apps? I'm assuming it's just the standard app stores.
Yeah,
you can get it.
Yeah. I think that takes you to the CDC's website that also tells you how to download it. But yes, if you were to go to any app store on whatever
You can
device
type
you
in
have, US
CDC,
space
US, MEC, and it'll, okay.
And you'll find it. Yep.
Okay. Just wanted to make sure it's clear for pharmacists.
Do we want to add some verbiage about that? We could just say follow that link, or we could also say something about like, search in,
Well, usually they say available on Apple and Android, whatever, on websites, but just the fact
Yeah.
that I was initially confused by what that meant.
that's why I'm wondering, yeah, if we wanted to maybe we could put like some parentheses there to say available for Apple and Android devices.
Yeah, exactly.
Do others like that idea? Yeah, okay. Could you add that? Thank you, Gary. Okay, I think we're gonna move on to the next one, which is the questionnaire. So not a lot of updates for conditions were added to the MEC, but there was an addition for chronic kidney disease, and there was clarification pulled out and an increase in the categories for sickle cell disease. So I think the only things I ended up adjusting on this included adding a question for if you have chronic kidney disease. So that's right there. And then later on, there is a question about, I just added it in with other blood disorders. Could you go up to the questions again, Gary?
Sure. And then staff member Runyon, just for those following along, this is number 2, the contraception self-screening patient intake form. Lorna, did you have to know what number that question was?
It was, you just passed it. So the first adjustment is right there for number 20. So number 20 question was added to ask, do you have chronic kidney disease? I didn't specify it out. Like, I know that the MEC breaks it down into end stage, needing dialysis and some other things, but I think sort of a lot of the other categories that we have in here for like diabetes and some of the others, we didn't get into the nuts and bolts on those either. So I just left this as straight. Do you have chronic kidney disease? Do others feel strongly about breaking it down, or? Because I think if we did break this one down, we might have to revisit some of the other categories too.
Dr. Virgin has her hand up.
Oh yeah, sorry, Dr. Virgin.
Yes, Committee Member Virgin. I believe that it is reasonable to keep chronic kidney disease not further defined, just because anyone who's going to meet the criteria for level 2, 3, or above, that's what we're really trying to pull out. Anybody that might be at higher risk for complications or intravascular disease related to this. So I am fine with it not being further differentiated because this would be a call out for a patient to follow up with a physician or clinician prescriber.
Yeah, totally agree. This committee member Anderson. Thank you. Any other thoughts on this one? All right. And then Gary, if you could scroll down a tiny bit further. The area where I added sickle cell disease is right there on question number 33, where I decided to add it into just sort of other like blood disorder type things. So lupus, rheumatoid arthritis, and then pulled out sickle cell disease all by, as it's as a specific thing, or any other blood disorders. If others feel strongly, we could give sickle cell disease its own question. I did not do that, but I would be good doing that either way. Yes, Dr. Virgin.
Committee Member Virgin, from my perspective, I am fine clumping them together. I also think that if we want to be, specific in, autoimmune disorders or blood disorders, that it would be reasonable to pull them out, but I don't feel strongly one way or the other. I might say, however, we did, in keeping with kind of the order or the hierarchy of different conditions, you do call out breast cancer, you do call out hepatic disease. Maybe I am going to articulate to just be consistent, and then pull the blood disorders into a separate line. I am thinking
Member
about,
Gibler, I agree. That's
Okay.
more clear. Since those autoimmune conditions
Oh.
aren't blood disorders, I just don't want to. We're just lumping too many things together there.
Trying to remember, Staff Member Runyon, could you pull up the MEC, which is where the vast majority of the changes were made? The blood disorders was already part of this questionnaire. I did add the word other, I will admit that, other blood disorders. Trying to remember if there were others like pulled out in the MEC. So one of the
Are those the only autoimmune conditions that they listed, lupus and RA?
RA was already listed.
I know they're listed already in this questionnaire, but is that the only consideration pharmacists, autoimmune conditions that pharmacists need to consider?
No, I mean, there's other autoimmune stuff mentioned. Like I think there's IBD is in there as a condition. Yeah, this was the document that I had mocked up.
So for the committee members, this is going to be mailing A1. If you
Thank
can't
you.
see this very well, you may want to open your own.
And this was the document that I used for myself just to sort of visually see where the changes had been made to all of the different categories. So if you see a red box around it, that means there was a change to it. And so let's see where some of this. Yeah, if you end up highlighting over all the little areas, I very specifically said what the differences were.
So Staff Member Runyon, of course, they're not stratified by organ or organ system or type of condition. So I can scroll around to anything that you want to look at. But in order to see whether or not there are any themes in terms of the conditions that are listed that might fall under a broader category that we could use to differentiate the questions on the questionnaire, it might be more difficult to do that here, but just let me know what you want me to scroll around, or I can do a keyword search for anything in particular.
And I think Committee Member Sellers, did you have your hand up?
Yeah. So when we're looking at this questionnaire, I mean, these questions, if anybody answers yes to that particular line, the pharmacist is going to be directed to this table and seek further clarification. That's the intention. Am I correct in that? Because
Yes.
otherwise we would have to like put a different question for every single condition, I would think.
Well, exactly. And this
Okay.
table is that you are looking at currently.
Mhm.
Like I said, this is the one that comes from the CDC. This is the updated table. And so what I had done is I had gone through and marked it all up. So it is a PDF now. It's no longer the CDC's I guess it's my version. But I marked it up to say where the different changes were from the previous version. And the reason I did this was because in our protocol, what we did for both the questionnaire and for the pharmacist being able to take the questionnaire and apply it to this is we created our own specific, like Oregon protocol specific chart that correlates back to the questionnaire. So if you're looking at the questionnaire, you'll see that there's all these little colors off to the side. And those colors correspond to these categories that we put into our own table, and was the vast majority of the updates done to this protocol was in that table. And I will admit that you'll see a lot of things in here for the types of conditions that are mentioned, but because they are a category 1 or 2 and that pharmacists could go ahead and prescribe for them, we didn't include every single one of these conditions in the questionnaire. We only included ones where there is a concern that pharmacists should be looking into further. So for instance, let me find one, like if you have somebody with dysmenorrhea, for instance, if you can see that on this chart, there is like the only concern maybe is a copper IUD, and even that is still like you might still be willing to give that to the patient, even though like we don't do copper IUDs, we would just stick to DMPA, POP, or CHCs, all of which have a category 1. So we do not, for instance, have a question on our questionnaire about dysmenorrhea. Does that make sense?
Oh yes, that makes total sense.
Okay. Oh yeah.
No, I just I'm looking through this, and the only thing that I don't see, and I realize that this probably sounds really silly, but so under algorithm B, or I should wait, right? We're going through one at a time. I'll wait. Never mind.
We are, but I'm wondering if it's helpful. So Gary, staff member Runyon, could you pull up the document that has the organ specific chart? It's part of, I believe.
Oh, I answered my own question and concern. It's all in there.
Okay, I think it's
Forget it.
just in the Prev Care document further down.
Staff Member Runyon, do you happen to have the number for that 1 through 6?
It's the most recent one that Jen had sent you an email on, because that was like the one that we were doing the most updates to.
Staff Member Runyon, give me just a moment. Is it the treatment pathway, or is it the
Yes.
chart that looked up? Okay.
Well, it's at the bottom of the treatment pathways. There we go.
Yeah.
So this is our version to correlate with the questionnaire. So I think the questions had been about sickle cell and adding that. So could you scroll down until you can find sort of the bright green coloring? I think it's on, not those greens. It's a little bit brighter.
Staff Member Runyon, I am red-green colorblind, so forgive me for.
Oh, no, I'm so sorry.
I still love Christmas, though. But, yeah.
Oh.
So
I'll try and tell you when to stop. So keep going down. Tiny bit further down. There we go. So the systemic lupus erythematous is one of the categories. There's RA, and then what used to be called blood conditions and anemias that included thalassemia and sickle cell disease had been broken down in the new version of the MEC. So, and it even gave sickle cell disease higher categories for a lot of the stuff pharmacists can prescribe for. So that means it was important to include it. Since they don't really call it, like give it that kind of category anymore, I would kind of maybe suggest we just get rid of blood disorders altogether, that verbiage, because they don't list it like that anymore. This is how they list it in the MEC, is they've broken it down into these categories as lupus, rheumatoid arthritis, and sickle cell disease. So those are the categories that are applicable that all got kind of put into that one question. So do you have lupus, RA, sickle cell disease? Like I said, the blood disorders was the previous name of the other category that the CDC had that like looped a lot of those together. So how do others feel about just getting rid of that altogether? So it only says lupus, RA, and sickle cell.
Committee member Gibler, I like that.
Okay.
And it looks like there are no other autoimmune conditions were listed. It's just inflammatory bowel disease, lupus, and RA.
Yeah, it's just a difference of how the MEC used to list
Yeah.
things. Yeah.
Now that I oriented myself a little bit better than I was previously, I understand now.
Okay. Is everybody good with that? And then we can move on. Sorry for the back and forth on all the documents. All right. I think the only other thing I changed on this document was to just get rid of the brand names there of Depo-Provera and Depo-Sub-Q. Any concerns with just getting rid of brand names and leaving that with, if it's an injection, there's only two types, they're IM and sub-Q. I just figured we'd leave it like that so we're not including brand names into things. Any concerns with that? All right, I think that was it for the changes I made on this document. The next document is the treatment care pathways.
Staff member Runyon, give me just one moment. Okay, staff member Runyon, this is number 3, the standardized assessment and treatment care pathway contraception. And this is also one of the documents that includes some comment from Jennifer Davis that you may not all have received. So just moving forward, keep that in mind.
Yes, thank you. When I was reviewing this document, this step felt super confusing to me the way it had been worded. And you'll see in my little comment, I understand why it was included because there is a piece in statute that says pharmacists are not allowed to continue prescribing contraception past 3 years without evidence of a clinical visit. So that's in statute. And so this was an attempt to try and make sure that we were including that information in this protocol when it got brought into the formulary committee. That being said, it just seemed really confusing. So I'm open to suggestions on how to fix it. This verbiage that you see here was my initial attempt at trying to fix it. But at the same time, it makes it very lengthy and wordy, and I kind of could see how all you really need is the exclusion criteria on here. And I think Jennifer was agreeing with that as well. She actually included the actual verbiage of the statute that that this step is trying to capture. So open to like, do we like how I adjusted it, or do we want to try and just get rid of the inclusion criteria and just leave it with exclusion criteria?
This is committee member Gibler. I do not like the way it's written now, and it's confusing, and I agree with you that maybe just leaving the exclusion criteria is more clear. That's typically not how exclusion criteria are written redundantly like this.
That's what my thought was too.
I agree. I think the exclusion criteria is very clear, and getting rid of the inclusion criteria makes more sense.
Okay, awesome. Yeah, I think that's kind of what Jennifer was starting to say as well in her comments, was that, yeah, we're getting the point across with just leaving the exclusion criteria, because that's really all this step was trying to do, was say that pharmacists are not allowed to continue prescribing. So do others?
And the next step is committee member Gibler just says no exclusion criteria or meets exclusion criteria. So that also aligns with just having the exclusion criteria listed.
Awesome. All right, I don't know if you guys would like, would you guys like me to be referring to myself as committee members? Me. Since I did a lot of these changes. I don't know how you guys.
Both.
There you go. It's me and committee member Anderson. So staff member Runyon, would you be willing to go ahead and just nix all the inclusion criteria there on step 1? And so all we're going to end up doing is keeping exclusion criteria.
Staff member Runyon, I'll give that a go.
Thank you. Let's see. I don't think there were any adjustments to anything else until I think I removed some stuff and adjusted like numbers and things like that. And I added units to blood pressure. So I did a few updates. So if anybody has problems, let me know with those updates. Oh, this was a change here in the provide counseling. What did I add? Oh, so I just added the information about using backup, because you don't need to use backup if the patient is within 5 days of their last period. So I just added a little bit of verbiage there. If you could, so this next one goes into depot specific. So the first one is the treatment care pathway for POPs and CHCs, which include the pill, patch, and ring. And this is just for injections. So as a reminder, back to that resource that was mentioned on the first page about how to like train somebody to do a self-injection. That was something that when this protocol got brought under the PFAC, we felt pharmacists, because it's in the SPR, is something that patients could do by themselves, that pharmacists would just observe a first injection and then could dispense the rest of the sub-Q if that's what the patient wanted to do. But I wanted to make sure that the verbiage fit that. So if you go, oh yeah, so this first step, if you could make that first step be just like the one above it. And then further down, there was some updates to include like self-administration for the injection.
Staff member, I need just to clarify, when you're referring to number 1, background information, you're saying make this like the one above it. Just need a little clarity on that.
So that it only has that
base, but make it similar to this, where there's just the exclusion criteria.
Correct. Yes.
Now, this one doesn't label exclusion or criterion, so just have that as well. Title exclusion criteria.
Oh, yes. Thanks for that.
Staff member Runyon, try not to pay too much attention to the formatting. It's not pretty, but we'll clean that up for you. What would you like to look at next?
So if you scroll down a little bit more, what were the changes I made there? I don't remember those. I think I just changed like numbers and stuff like that on the questions because we have new questions. But I did change some verbiage a little further down where it talks about, no, I think this is the first one. So there we go. A little further. There we go. So in step number 5, just to be consistent with the idea that somebody might get administered or dispensed the sub-Q formulation, I just included more information here to say discuss plans for follow-up injections instead of visits. But if they still want to get IM injections and come in for visits, that would still fall under injections. So that should happen every 3 months. And then if getting IM, stress importance of returning for the next injection within this time period, and then provide patient with specific calendar date range for the next injection. And then I think that was it for these changes. Any questions on those? Because you'll see that there already was information about if dispensing DMPA sub-Q for self-administration, the first self-administration must be observed or by an appropriately trained authorized healthcare provider after providing the patient with education. And then the patient may complete subsequent. Thanks for the highlight. So that information had already been added. I was just trying to clarify the step just above that to include that type of visit where you might end up dispensing sub-Q for the patient. Any concerns or problems with those? That's all I was trying to do, but with no concerns, then we can move down into the big chart. All right, so here's the big chart, which I thought it was funny. We didn't include the ring under the CHC, so I've added that. And then I went ahead and I think I sent you a version that got rid of all those little letters in front because I didn't understand what those were for. They're not on the questionnaire. So anyway, is this the version that breaks down all of the 3s and 4s and 2s? Staff member Runyon?
Staff member Runyon. This is what you're referring to here. perhaps under CKD or chronic kidney disease?
Yeah, so there is a newer version that so and I suppose other committee members can chime in as well. The first version of this showed that I ended up finding there that what we had done in a situation where one of the methods for a specific condition had both a situation where the pharmacist might be able to prescribe and one where they would have to refer based on a 3 and 4 condition. It had gotten broken down as to why that was. And so that ended up being the case with CKD when it came to POPs. And so POPs, it turns out the reason why you might prescribe versus not prescribe is the type of POP. There are 3 types of POPs now. We just talked earlier about the OTC one, Norgestrel, that got approved. The one that most people are familiar with, that's been around for decades, is norethindrone, also referred to as the mini pill. But in the last, I want to say 5 or 6 years, we've got a brand new one that's drospirenone. And drospirenone, for all of your pharmacology folks, is very similar to spironolactone. And it has mineralocorticoid types of properties. In some situations, especially in somebody that would have CKD, it would elevate potassium. And so that is the reason why it would have a concern in somebody with CKD. So in that specific situation, the concern from the MEC is that you could do Norgestrel and norethindrone, but you would not want to do drospirenone. So what Jennifer was proposing is that in our version of the chart, we break down that reason. And so do you want me to resend it to you, Gary?
Staff member Onion, currently sifting through the email. Just a moment. I might be able to access it quicker than emailing. I believe I have it, and staff member Onion, just a moment, and I'll pull it over onto the desktop so we can take a look.
Okay. So that was one of the big changes that Jen had suggested we make from the version you guys got in your emails, because some of these new changes involved like a situation where you could and a situation where you couldn't, or the pharmacist, that sort of thing.
Staff member Onion, Lorinda, it looks like it's the same one that we were looking at. So if you have access to that, you can send it. It might be the quickest route.
Okay, I just sent it to you again.
Staff Member Runyon. And Linda, did you send that to my email or the formulary inbox?
Typed in your name. It says Gary Runyon.
Correct. Yeah.
It should start with V2.
Staff Member Runyon. Let me try this one. We'll take a look.
Yep, there it is. So this version, you guys can see how under CKD, there you go, right there, how it got broken down. So the three types of CKD in this MEC that are listed are current nephrotic syndrome, hemodialysis, and peritoneal dialysis. And then it states, you know, if there is concern for hyperkalemia, that you should not be using nitrospironol. So that's kind of how that got broken down. Hopefully this makes sense. And every time there's a little asterisk, it just kind of mentions, you know, there's more information in the MEC, like the text of the guideline itself. So that's where like either going to the guideline or using the app are helpful. So.
Committee Member Gibler, what, when you said concern for hyperkalemia, is that appropriate language to use for pharmacists? Like, how would they be, based off of these conditions, be concerned? Like, what would be the objective criteria to be concerned about hyperkalemia? Obviously, these are all three are risk factors for hyperkalemia, but
yeah, I mean,
but do they have it or do they not have it is what we need to know. And I don't know how we.
You're right. And that is actually what I have here. Without hyperkalemia or with hyperkalemia are the categories that I put into the chart.
Would they need to access a lab to look at the latest potassium levels?
I mean, every single one of these are based on self-report in the patient questionnaire. And so like if you go to diabetes, for instance, which is just above that, the only question on the questionnaire that we have is, do you have diabetes? And it doesn't ask about history of gestational, non-vascular disease. Are they insulin dependent? Are they not insulin dependent? So in every single one of those cases, the pharmacist needs to be doing more follow-up questioning with the patient to find out what's going on. If they have the ability to look at labs, that would be great, but there's nothing that we have in our protocol that says that they have to do that. Of course, they can always, you know, try and err on the side of caution and you know, refer if they would like. But that hasn't ever been the intent of this protocol, was to be able to look at labs. And I think Committee Member Sellers, you have your hand up.
Yeah, this Committee Member Sellers. Can we just get rid of the hyperkalemia parts and just say, just don't prescribe the drospirenone ever for these conditions? I mean, wouldn't that make it easier?
I mean, I suppose so, if we want to do that. But I guess I will say this document right here is more of like trying to reflect what the MEC says, because in our steps that we have above for the treatment care pathway, the step for this is where they just need to be going back to the MEC and seeing what that says and looking for the categories. All this is trying to do is say, if you see this question on the questionnaire, these are the categories that it corresponds to in the MEC. So this document isn't like a required piece that they have to use. It's just more of a help. And really what they're supposed to be doing is going to the MEC.
Okay.
So that's what I was trying to do here, was just convey what the MEC is saying and just break it down as to why there was a category 2 and 4 given on POPs. I think there were a couple of other places where things got updated for, like, there was a history of ischemic heart disease that had a 2 and 3. Same with stroke. Actually, I don't know that I adjusted those. That's what it was previously. And then we talked a little bit already about the changes that were made below with the blood disorders piece and how they now have that separated out by like rheumatoid arthritis and sickle cell. So that's now what that looks like. And that's an instance in rheumatoid arthritis where they actually gave the injection a category 3 if somebody's on long-term corticosteroid use. The reason for that is because the injection, if you're using it past 2 years, has been shown to reduce bone mineral density, and long-term corticosteroid use also reduces bone mineral density. And so that's the reason for 3 with DMPA if somebody has that. So that's where that breakdown came from. That was an update to the MEC this year. I think those are some of the only really big ones. So you guys have seen CKD now, you've seen sickle cell, those were big updates. There were a handful of updates to DMPA, especially with regard from changing things category wise, but I feel like they were mostly just changes from category 1 to 2. So I've updated this table to reflect all of those changes. And if you want to go through all of them, I guess we could. I don't know what you guys would like to do, but that's where the bulk of the changes came from. And so you have like the annotated CDC version, and I used that to update this. This is where the vast majority of the changes came from. So are there any questions or thoughts from committee members? Oh, it does look like there was a change for DMPA on solid organ transplant too, that added a category 3 for something. So if they have a history of risk or risk factors for non-traumatic fractures, that sort of goes back to DMPA's bone mineral density piece. So there is a category 3 now in that very specific instance for solid organ transplant patients. So that was another place where I broke down the 2 and 3.
Staff member Runyon, are there any other conditions you'd like to take a look at? You have to scroll through. If not, perhaps go to the next one.
I don't think so. Are there any other questions before we move to the final documents? And I don't think there were a lot of changes to the other stuff.
Yeah. Staff member Runyon, just a moment. I'm saving that document. We'll put the next one.
Chairperson Virgin will just state that I appreciate Chairman Anderson's attention to detail here.
Thank you.
Staff member Runyon, staff member Melvin just informed me that in terms of changes to the last or the remaining documents, I think there was one notification change or one reference change to provider notifications. And just formatting changes on the last one, the visit summary. And otherwise, there weren't any substantive changes to anything that we're aware of or that we saw.
No, there really wasn't. That's what I was thinking too. And I do think those changes can be seen in the document that you sent to everybody, because I don't think we adjusted anything since then. So only updating the guideline links to be the current guidelines, and then updating the version, for instance, at the bottom of the screen. I think that was it. All right. I think those are all the major changes. Like I said, the vast majority were in that treatment assessment pathway area. So any other discussion on updates to this? All right, I think I would like to make or ask if there is a motion to move to recommend the contraception statewide drug therapy management protocol version 11 of 2024 as revised today to the Oregon Board of Pharmacy for review.
Committee member Gibler, so moved.
Thank you. Do I have a second?
Committee member Virgin seconds.
Thank you. So committee member Anderson, I approve. Committee member Gibler.
Aye.
Committee member Myers.
Aye.
Committee member Sellers.
Aye.
And committee member Virgin.
Aye.
Thank you, everybody. This motion passes.
For your work on this.
It's one of those, we got the update, and I'm also making updates to the training program now too. So it's a lot of my time lately. Do we want to take a break before we dive into vaccine stuff? Do we need the SMEs here?
This is staff member Melvin. We do not have any SMEs joining us today. So that's up to you, the committee. We were slated to have lunch between 12 and 12:30, which looks like that may need to happen based on what's left on the agenda today.
Okay. Because we've got all the, oh, that is a lot of vaccines. Okay.
Not a lot
Um,
of changes though. Didn't go too long.
and the vaccines are all we have left. Is that right?
Staff member Runyon, that's correct.
Okay, so I would like to propose that we take our lunch now, or is that, do we need to stick to the 12 o'clock?
No, the committee can make that decision.
What would the committee like to do? This committee member Anderson.
I would like to go through maybe one protocol. Is that okay? Unless someone needs to take a break. I'm good till noon, but
So
that conflicts with what you just suggested, committee member Anderson.
that's,
So if you need
I'm
to
fine
break,
either way.
I'm happy to break.
I don't care. I guess I just figured what we have left are to go through some of the vaccines. So we have to go through COVID, Hep B, meningococcal, pneumococcal, and RSV. So and it does sound like there's not a ton of changes, but so I guess I was just thinking lump all the vaccines together after lunch, but I'm also fine with going through one or two.
Indifferent either way.
Okay, so we have an option to break for lunch now. We have an option to go through one or two. What do other people think?
I would vote for going through one or two now.
Agreed.
All right, we're leaning more towards going through one or two. All right. So then I will go ahead and turn the time over to the staff to start discussion on COVID.
Right, Staff member Runyon will pick up with mailing 8-2, which is our coronavirus vaccine protocol. Just a moment, I'll share the screen. And on this one, we're correct in that there weren't many changes, but due to the formatting and the layout of the protocol itself, those changes show up in multiple different sections and in a few different ways. So there may be some opportunity if the committee sees fit to streamline some of this, if you will, or change the presentation in such a way that won't have any clinical impact, but might make it a little more user-friendly for the pharmacists out in the field. Just some options as we go through. First, for your consideration, everything in highlight here, it's in yellow, are things that I have did since we mailed those to you. And there were some updates from the ACIP, and they met October 23rd and 24th, but they didn't publish the recommendations until after we sent the mailings out. So that's the reason for these amendments that you weren't privy to prior to. First off, in the what's new section, we do have this reference to the PrEP Act, which will be ending, the 11th Amendment will be ending December 31st, 2024. And we can scroll down. I'm still on the first page, for example, for those of you that are following along the public call. If you're looking at the protocol under 3A, Table 1A, there's a note that gives reference to the Act and the fact that it will be sunsetting or that it'll be stopped on 12/31/2024. But my question to you is, do we want this in a more conspicuous manner? Do we want it at the top? Because without any additional communication, just afraid that some pharmacists might overlook that. And of course, that's what allowed our pharmacists to give COVID vaccines down to age 3. So 3 through 6, whereas in statute, it would revert to 7 plus. So it could potentially have some significant impact. And so again, the question is, do we want it here under the note, or do we want to add it up at the top under the what's new section to make it a little more conspicuous?
Committee member Virgin, I would agree with the importance of making it more conspicuous in the way that it is currently presented.
If there are no objections to that. The next one under the what's new section, I've added kind of a summary of the ACIP guidance and the recommendations. There are a couple options here because, again, as I mentioned earlier, there's so many references to the changes themselves in the appropriate context or in the appropriate patient subpopulation. I didn't see the need to necessarily lay all of those out here. They're over here on the right. As you can see, it's a pretty big list. So we could include all of that up here, or we could simply just refer them to the protocols, as I have here, sections 3 and 5 for additional information, as these recommendations are stratified based on all the factors that I have here: age, underlying conditions, vaccination history, vaccine choice, such as Novavax, et cetera. And do we have any preference on that?
This is Committee Member Anderson. I like your idea of just doing a synopsis and referring to the other further down in the protocol for each of those.
Okay, if there are no objections to that, we'll continue on. So again, not a lot of changes, but they show up in a lot of different places here. So we'll scroll down to the next amendment that was made subsequent to those recommendations being published. And some of the changes here are just formatting.
Staff Member Runyon, this is Committee Member Gibler. Yeah, I just want to make a general comment on some of the additions and then a few areas that were missed. But last summer when we discussed this protocol, we had asked that when you're discussing specific age groups, that we not use the dash, but we either say age blank through blank or up to a certain age. So where it says 6 months - 4 years, it should say from 6 months through 4 years, for example. And you'll see in other areas of this protocol, they're all written out through. But I just ask that we be consistent because we are giving very specific ages. And I can help. I went through earlier and just highlighted a few. I can help kind of show you where those are, or you can do it later.
Staff Member Runyon, thank you for that. So I did reword this just for clarity. And there was the additional doses that were recommended. For example, recommendations for children ages 6 months through 4 years who are moderately or severely immunocompromised. Added the references here. Then I did that in such a way that this stem sentence applies with the rest of these. And again, you're going to see the same verbiage about additional doses and the reference to shared clinical decision making for all of the age groups with moderate or severe immunocompromisation. I'll go back through it again and change the dashes here. So same thing here. We have this age group same recommendation. And we have the additional doses here on the bottom, same structure of the stem. And so basically the recommendation, so we can't see it, I've included it at the bottom, however, is anyone 6 months and up, 6 months through 64, that are moderately or severely immunocompromised would qualify for this additional dose under the shared clinical decision-making model. And the reason it's 6 through 64 is at 65, those individuals, regardless of any underlying conditions, are eligible for the additional doses under the same decision-making model. So that's the reason for that. Okay, same stem here, additional doses as well. And I'll just pause for a moment. So for anyone following along, we're down to section 5, recommendations for use. So if you'll notice, under recommendations for use, basically what we do here is we spell out, or literally write out, all of the recommendations that are housed in the tables up here. So there, for the most part, isn't any novel information. So that would be one of the points where it could be an option if the committee sees fit to kind of pare down this document from something that's around 17 pages to something that's a little more user friendly. It's just for your consideration there. Again, all of these things are in the table. And Andrea, yeah, I can see a lot of these. You're right, are here. I didn't make these, but I'm happy to fix them. So I'll make a separate note on all of those that were already present. Are there any feelings either way on that we want to keep all of the text? Or do we want, kind of a more pared down version or somewhere in between?
This is committee member Sellers. I would opt for a pared down version. I mean, I feel like redundant information, when I'm reading these protocols, it always makes me think I'm missing something when it's literally the same thing in 2 different forms rather than having it actually provide additional supportive information.
Right, and then there's the habit of cross-referencing to see, okay, say it's the same thing here as it says here, okay, I'm good. And that all takes time. So committee member Gibler agrees with paring down.
Yeah, step and we're running it. For example, here, recommendations for use, we could keep the references to the extended interval and minimum interval, for example. I don't think those are present in the other tables. And traditionally, that is the sort of information that you would include or focus on in the recommendations for use section. And that's also consistent with the other protocols that I'll highlight as we go through them. It's rare that we actually use this section to kind of reiterate via text what we've already covered in the previous tables. So could cut really all of this out here. And then renumber that, and then just leave this there. And then this, in general, we could keep as an umbrella statement up here without, going into any delineations about age.
Yeah, that section 5's entitled recommendations for use, should it be renamed to additional considerations for use or something along those lines? For example, the extended interval section that we leave in is a consideration. The extended interval consideration applies only to the following people. But I only ask that that be consistent across vaccine protocols as we update them, that there's some level of consistency in how they're titled. It does make it easier for busy pharmacists to quickly go through the protocol without focusing on areas that look new or different from other protocol sections.
Thank you for that. Staff member Runyon, even here we've added this. I believe it's also covered in one of the charts above. Just a moment. It would be, again, an option to take that out if you wanted. Yeah, so we're under this section, Table 1C, immunocompetent individuals ages 12 years and older. So we've included that in text here. People ages 65 and older are recommended, the language has changed, to receive 2 doses of any 24, 25 COVID vaccine, et cetera. So it covers all of that as an exception to the table or as additional information. And then again, it's down here in 5. So we could, even though I've added that, it was just keeping consistent with the document itself inherently, and we could also cut that out. And this stuff is in there as well. We could keep, as we did previously, I can take a look at these to see if the extended interval and minimum interval here is the same. Yeah, I think we only really need that once, so. Hey, Steph and Maroney, do we have a consensus on that, or is anyone else like to want to weigh in or have any considerations either way?
You're asking specifically for section 5, what you've done so far.
Staff member Maroney, that's correct.
Okay, no, this is committee member Gibler. I have no additional. I agree with the changes.
This is committee member Anderson. I agree as well.
Committee member Sellers also agrees.
Staff member Maroney, thank you. I'm sure the pharmacist out in the field might thank you as well. So, let's see, let's go to B. Vaccine schedule for individuals with moderately or severely immunocompromising conditions. So essentially what I've done here, I've taken the recommendations and instead of adding them, as you'll see down here, the bottom section in each of these segments that went through the age groups had information or verbiage about additional doses. So again, we were listing that several times here. And again, all of this information is present in the charts above. So this is something if we wanted to keep, we could keep here as just one statement as opposed to repeating it for each age group. I'd recommend keeping this as well. And then could get rid of all of the age groups as we did before because it's all up in the charts, the preceding charts. And then that would leave us basically with this pared down additional considerations for use section, which going forward we try to keep consistent across the protocols as applicable or in as much as we're able to. And then that would leave us just going to number 6, which is contraindications. Stefan, running any additional thoughts on that or? Okay.
They can't vote in thumbs up.
So,
Make sure they're not just voting thumbs up.
we just need a verbal, if possible.
Oh, we're not daydreaming. Committee member Gibbler agrees.
Yeah, this is committee member Anderson. Yeah, I think our silence just means we agree, but
Staff member Runyon, it was silent. I did hear some stomachs rumbling, though. I think maybe that was mine. I'm not sure.
understandable.
So the next section here are contraindications. General statement, you'll see consistent throughout the majority of the vaccine protocols. One thing I would bring up for your consideration is there are a lot of ingredients here, a lot of inert ingredients, and excipient ingredients, of course, fillers, stabilizers, etc. The thing to consider is if there are any changes that occur to this between year, you can see between all of these formulations, I mean, there are well over, best guess, probably 100 data points here. Is there any consideration for, since all of this is available in the package insert, which someone would arguably have access to if they're giving the vaccine, unless they've gotten it in a baggie from an interstore or something from another pharmacy, in which case they'd have access to it online, and we even reference it at the bottom. Is there any consideration for perhaps getting rid of this section as well?
Right,
Literally,
Committee member Gibbler, I had made this recommendation last summer. There was no movement on that discussion, but I think maybe the staff was going to consider looking at that more. But I absolutely agree that removing these ingredients not only potentially can save us from the committee to having a review if there's, if they change one little ingredient, but it's also widely available for all pharmacists who are immunizing anyway. So a simple referral to the package insert or prescribing information has all of this, and they'll guaranteed have the most up-to-date version with them, which is faster than we can do.
This is committee member Sellers. I agree with committee member Gibbler.
and I could, Staff member Runyon could add some general comments here. See package insert for ingredient list, or however you'd like to word that, just so we're referencing that.
Yeah, I see most updated manufacturing prescribing information for ingredients, or how are they, all these, I guess, excipients and ingredients, or contents, maybe, vaccine contents. But I don't think we call it package insert anymore. Is that still a thing?
I think we use.
I thought
Staff
it
member
was.
Runyon, I think we use PI at the bottom here. It could be.
Yeah, which also stands for prescribing information. I think that if you go to FDA and manufacturer websites, they call it prescribing information labeling. Everything's available online. It's not a little leaflet in the box is no, it's not the primary way of accessing primary prescribing information. But if someone else understands it better than I do, that's just what I've known.
Staff member running. I just like my paper, Andrew. I'm old school.
Formulation contents, maybe.
Okay, so we have an amendment that says see most recent prescribing information for details about formulation and contents. Is that satisfactory? I'm happy to reword in either way.
This is Committee Member Anderson. That's satisfactory for me.
Staff member Runyon, I appreciate that. There is an additional, I think, layer of liability that we may create as well if there is a formulation or reformulation and there are a couple of excipient ingredients that kind of slip through the cracks here. If there were some sort of allergic reaction to something that wasn't stated here, that could arguably create some additional liability that wouldn't be present if we're referring them to the prescribing information.
Yep, I agree. That's why I always like if it's in the prescribing information, I do not like to write it down and like even dosing tables sometimes, but not in protocols, but just in my documents that I'm writing.
Okay, and staff member Runyon will continue. We're in section 7 here. No changes under warnings and precautions. Moving through section 8, all of these were just spacing, so no changes there. And under 8J, as in jump, there I believe we had 2023, 24, which has obviously been replaced. So I just updated that to 24, 25. Moving on through section 9, no changes here. Section 10, storage and handling, nothing there. And then, of course, the only reference change was the one to the recent ACIP recommendations. Again, this says August 29th, 2024. The interesting thing when you go to this link is it's the CDC's page, and that's when the page itself was updated or published, but it gives a link to the ACIP recommendations, and the link there gives the appropriate date. Take a look here. So here you can see it does say August 29th, but down below recent meeting recommendations, it talks about the October 23rd, 24th meeting that we've referenced. And then this is just a copy and paste of, what you see in the document or vice versa. Andrew, you have your hand up?
Yeah, this is Committee Member Gibler. I just have a question about the utility of the storage and handling section, whether that is these protocols are the resource for pharmacists to understand how to store and handle vaccines, or do they use again, the actual FDA labeling.
Looks like there's an OAR for that. Sorry, this is committee member Anderson. I'm wondering if that's the reason it got included, because there's an actual OAR, but
The OAR
I agree. I don't, oh, I'm guessing it just is saying that like pharmacists or pharmacies are required to make sure they have the appropriate, you know, storage ability, and that they're documenting that things are staying in the right temperatures and things like that. But I would agree that this is a lot of information that is probably also available with package insert stuff.
It is, and I think it's also just an expectation with the OARs. Sorry, this is committee member Sellers.
I mean, I'm okay with keeping it in if this is the go-to resource that pharmacists are using to store. But I mean, I wouldn't think it is, but
Staff member Runyon, from what I gather, it may have been left over as carryover from maybe the OHA versioning that we absolutely did not copy from whatsoever. So I think it may be a remnant from that. And the only thing in terms of what I see, as a very recently practicing pharmacist, the things that I see most often used in this sort of instance would be just the storage and handling information specific to the length of time that's viable at refrigeration versus freezing, et cetera. The big change this year for the 24-25, which is a pretty big departure from the previous iterations, was the Moderna is stable for 60 days, up to 60 days at refrigeration, whereas it was 30 days in every previous iteration. But again, that information should be present through a multitude of platforms. But that's probably most routinely what I see referenced from these charts. And Andrew, I think you have the right idea. Does that justify keeping the entire thing? Not for me to decide, but happy to do whatever you choose.
This is committee member Anderson. I mean, I don't know if pharmacists are actually using the chart, then maybe we keep it. But I agree with the idea of trying to pare things down. Looks like we are getting close to noon. How are we doing with getting? Were there many other updates?
No, that would be the end. And if you'd like, if we cut all of this out, I could replace it with something similar to what we used in the previous one. Just the copy and paste here, and we could wordsmith that in any way you want. So get rid of everything below, and we could just say, see most recent prescribing information for details about storage and handling.
I mean, this committee member Anderson, I like that idea.
and that would be my preference, committee member Gibler. But if anyone thinks these are a helpful resource, additional resource, even though it's redundant from all the other available information out there, that this might be easier. But knowing this is a prescribing and administration protocol, this is not their source for storage and handling, which is run by pharmacy technicians on inventory and verified by pharmacists outside of this setting where they're prescribing and administering. But I mean, it's nice, but I like it pared down if we can.
Okay, Staff Member Runyon, we have a consensus on that. If we do, then Or I'm asking, do we?
We've heard from
Let me be clear.
Committee Member Gibler and Anderson agreed to it. How about the other folks?
All right, and Staff Member Runyon, that takes us to the end of this one.
Yeah. Committee Member Virgin, I think that's reasonable to provide additional clarity and the purpose of the draft in the first place.
And this is Committee Member Gibler, just at the very end in the appendix. I'd prefer not to have something pasted in. But that can just be typed into. That's important. The summary of recent changes, if that's important to add in the appendix, which I'm not sure it is, but if it is, can that just be literally just typed out instead of pasted from the webpage?
Oh, this is Staff Member Runyon. I tried to allude to that in the way I wrote it. That was just for our reference if we needed it. It's
okay.
not part of the
Not part of the protocol.
So, yeah.
Okay.
Yeah.
That makes more sense. Perfect.
Yeah. It's an eyesore. Otherwise, I agree.
Yeah, a 19-page protocol is impressive.
So I think since this is the last of Staff Member Melvin, we're ready for a motion or to break for lunch. Back to you.
I think both. Let's go ahead and approve this since we've seen it and then break for lunch. So is there a motion to approve the coronavirus 2019 vaccine statewide drug therapy management protocol version 11 of 2024 as revised today to the Oregon Board of Pharmacy for review?
Committee Member Virgin makes that motion.
Thank you. Do I have a second?
Committee Member Gibler seconds.
Fabulous. Committee Member Anderson approves. Committee Member Gibler.
Aye.
Committee Member Myers.
Aye.
Committee Member Sellers.
Aye.
And Committee Member Virgin.
Aye.
Fabulous. This motion passes. Now we are going to take a break for lunch. So 30 minutes, we will reconvene at 12:34 p.m. Thanks, everyone.
Thank you.
Thank you.
Thank you.